How's it going, everybody? I can't see your lovely faces, but I know that you're there, and I know that there are still people logging onto this webinar. I am very excited to present this to you today. I also have with me my colleague Shalisa Gladney. So we're doing a two-part series. Of course, she's not the primary presenter on this one because originally she had some sort of plans, but then they ended up getting canceled. So now she is in the chat helping answer questions too, and may also interject at certain points if she has things to offer. Let me tell you, oh, I gotta click onto this. Okay, let me tell you a little bit about myself. I work for RVAP. I'm the volunteer coordinator, but that doesn't anywhere near encompass all of what I do. I manage a volunteer pool of about 70 people, and I'm also managing a number of advocates that provide overnight on-call services within our organization. But on the side, I also have my own caseload. I work primarily with clients who have suffered medical abuse, or their perpetrator was someone who was a medical professional. I also work a lot with the LGBTQIA community. I got my start in advocacy back at Transformative Healing in 2016. Unfortunately, we got defunded, and that's how I found my way over to RVAP, because I wanted to continue working in the anti-violence movement. I am one of the co-creators and facilitators of the Queer Health Advocates program at RVAP. So that's a program that provides medical accompaniment, not emergency medical accompaniment, to LGBTQIA folks to help foster a more positive relationship with their healthcare providers. I'm also a co-facilitator of a queer art healing group. I kind of have my fingers in a lot of different pots, and you'll also notice that I am a full spectrum doula, and we'll talk about what a doula is a little bit in this presentation, but more so in the next presentation. Hey, Shalisa, do you want to introduce yourself real quick? Shalisa?
Sure, I'll do a quick introduction. Hi, everyone. My name is Shalisa. I also work at RVAP. I'm the campus prevention educator. I'm a doula. I do work within queer Black communities. Yeah, I'm excited for this presentation. And then tomorrow I will be, not tomorrow, next Thursday, I'll be joining Storm in leading the conversation around like advocacy and this work. So thanks, Storm.
Thank you, and thank you so much for helping us get questions answered today and providing so much input for this series. So today, I'm going to preface it with this. I have never hosted a webinar in my life, so hopefully everything goes a-okay today. In the meantime, though, here's what we're going to talk about for just today. Right now, we're in Connecting the Dots Part 1. So we're talking about defining obstetric violence and medical violence. We're also going to explore a brief history of birth care and gynecology in the United States, also how that morphed into the professionalization and medicalization of birth care, and we're going to do a brief overview of the Black maternal health crisis in the United States. Next time, we're talking about the impacts of advocacy and doula services and other advocacy programs and how they can help combat medicalized violence and restore power to birthing people. And we're also talking about the impacts of postpartum care, or care after pregnancy termination, meaning everything related to infant loss, abortion, miscarriage. Yeah. Okay, so what does birth have to do with sexual violence? A lot, actually. I think that in our movement, we don't often think of sexual violence as having much of anything to do with birth care, but it actually has a lot to do with it. But to understand that, we need to talk about obstetric violence first before I make the case for this. So obstetric violence, it's an umbrella term, right? It includes a lot of different things in healthcare settings for the most part, but it's about disrespectful attitudes, coercion, bullying, discrimination from care providers, lack of consent, especially for examinations or treatment, physical abuse during perinatal care. So there's a lot of different ways that that manifests. The key component of obstetric violence is about the lack of consent for medical procedures when it's happening. Consent looks very different in medical spaces sometimes, but consent isn't just about sex. So when we think about consent work the way that we do it in the sexual violence movement, we often kind of use something similar to the Fry's model. So it's freely given, reversible, informed, enthusiastic, specific. Freely given, meaning that person doesn't feel pressured or coerced into giving that consent. Coercion and consent are the exact opposites of each other. So coercion also involves repeatedly asking someone after they said no. Sometimes it involves making threats if a person doesn't comply. That's what we traditionally think of when we think of coercion, but coercion is a broader umbrella than that. For the most part, it's reversible. In medical spaces, for instance, you can't just put somebody's gallbladder back into their body after you've taken it out, but up until the moment of an irreversible procedure, a person should be able to say no, regardless. It also has to be informed. So patients have to know all of their options and have the right to refuse treatments. If you don't know what all of your options are for a treatment, it's not true consent. Additionally, we say that it has to be enthusiastic, which can be kind of difficult to navigate in a healthcare setting. So I'm not particularly enthusiastic about having a needle shoved into my arm. I actually have a needle phobia, but I am enthusiastic about not catching the mumps. So I do have some enthusiasm when I'm consenting to regular vaccinations. It's also got to be specific, which kind of ties into how informed consent operates. So just because somebody consents to one aspect of a procedure doesn't mean that they consent to all aspects of a procedure. I think it's important to note too that when I talk to providers about the concept of consent, most are on board with the idea of providing informed consent to patients. Some believe that the hospital consent forms are all-encompassing in a way. Hospital consent forms are not all-encompassing when it comes to consent. So consent to one form of care or generalized care from that entity doesn't mean that they can just subject you to procedures later on that they haven't talked to you about or given you a lot of information about. It's also important to note that hospital policy is not law, but I'll get into that a little bit more in the next presentation that we do. So bottom line, if you haven't directly asked a person if you can touch them, you haven't gotten consent, especially in medical spaces. With this in mind, I want y'all to think about your last doctor's visit. Did they ask you to get on the scale? Or did they tell you to step on it? Did they ask before taking your blood pressure, or did they just put the cuff on your arm? Did they just stick the thermometer in your ear, or did they ask first before they started taking your temperature? Did your doctor explain all of your treatment options to you, not just the one that they felt was best? Were you told that you weren't allowed to do something or were advised not to? Thinking about all these things, I want to ask y'all, and it's open, we can call on you too for this one. What do you think would happen if you said no with your doctor or wanted something different from the routine care that they provide? Does anyone want to share with us and raise their hand and participate? Raised hand. Okay, how do I?
We can help you with that.
Please help me with that.
We have Araceli Martinez. So I'm going to unmute you, Araceli, so that you can share with us your experience and ideas.
Sorry, I have TV in the background, so you might hear the TV from my kids. But they might just get like frustrated or say you're stopping them for performing the treatment they need to or stuff like that, that you're preventing what that needs to be done for you, you're interfering with it.
Yeah, so there's a lot of pushback, like it sounds like in situations that maybe you've even encountered with other doctors when you decide that you want to say no to something that's routine. Others that raise their hands.
We have Danielle, so I'm going to allow you to talk right now, Danielle.
Can you hear me?
Yes.
Okay. I think it's possible that they could document in your chart that you weren't getting adequate prenatal care, or start making things more difficult for you, especially if they have some bias towards you already. They might start documenting that you're, not taking care of your child, or you not have the best interest of your baby. Like there's so many things that they could do to really mess with your medical records.
Yeah, like they're branding you as a difficult patient in a way.
Right.
Yeah. Thank you for that input. And I think we had one more that raised their hand.
I think that was everything.
That was everything.
But there's some in the chat box. Shalisa, do you want to read some of those?
Yeah, I can. So one said, I recently took my daughter to her five-year-old well child check, excuse me about that, and the doctor had to check her privates to make sure everything was okay and didn't ask, just said, I'm going to do this. My daughter had a bad time and I felt really scared for a few days.
Oh my goodness. I'm really sorry that that happened. That's not okay that that happened, because a doctor needs to get consent every time, and especially with children, it's very important to explain what's going on, because the lessons that they have in the doctor's office should be that they have bodily autonomy and that they have the right to say no if they want to, and they also have the right to have things explained to them. So that, yeah, that's actually a form of medical violence. Okay, thank you for sharing that with us too. Sumaya, I saw Sumaya raise her hand.
Sumaya, you're allowed to talk now, so you can unmute yourself.
Yeah, it's about one of the immigrants, women here from our community here, the Sudanese community. She is circumcised really the traditional way, and she asked the doctor many times to cut, but they refused to cut until the last minute. As soon as they cut, the baby came out. So she suffered a lot because of that.
Right, they refused an episiotomy, it sounds like. Yeah.
Yeah.
That's yet another form of medical violence too. These are examples, yes. Thank you for sharing that with us. Okay, so y'all have heard at least a couple different ways that obstetric violence manifests. Let's talk about it in depth. So consent is that primary thing that we're looking at. We're not just looking at whether or not a procedure was performed. We're looking at whether or not there was consent, real consent, informed consent for that procedure to be performed. When we think about obstetric violence, one of the primary things that I think about is coerced or forced pelvic and vaginal exams. Also coerced or forced episiotomies too, or in some cases, the refusal to do one. An episiotomy is a cut that's made into the vagina that allows for more space for a baby to come through. Sometimes they're performed when the baby is stuck on its way out. But there are some medical circumstances under which an episiotomy would be necessary. They were also considered part of routine care in the United States for a long time, even though it's not evidence-based to do so for every single birth. A lot of times too, I see coerced or forced cesarean sections, including C-sections by court order, or court-ordered, sometimes coerced or forced inductions, so getting induced to give birth. Physicians threatening pregnant people with court orders is not as uncommon as you'd think it was. If you sift through the stories within the doula community, especially online, you'll find numerous accounts of this happening to people, birthing persons in the United States. Also, sometimes people will use physical force to prevent birth until the doctor arrives. So in one case, back in 2016, Carolyn Malatesta won her case against a medical center in which a nurse had physically held her baby's head inside of her pelvis for 10 minutes waiting for the doctor to show up. And it caused permanent nerve damage and a lot of chronic pain that she still deals with to this day. Additionally, holding a pregnant person down to a hospital bed or otherwise restraining them is a form of it. Healthcare providers saying sexual comments about a pregnant person. So like if you think about, I think it was like a couple months ago, Evelyn Yang came out with a story about getting sexually assaulted by her doctor and having sexual commentary said towards her when she was pregnant. That's one form of it too. There are some other ways though. So what we think about in the last slide is some of the more traditional ways when we think about obstetric violence, but it also encompasses several other forms of neglect and abandonment too. So it can involve non-consensual drug testing of the birthing person and their baby, abandonment, and delay of necessary care. You see it a lot more often in populations that are considered marginalized, or otherwise people who are branded as difficult patients in the hospital setting through their medical records. People getting yelled at in labor, being ignored or refused their requests for help, which is what happened to Serena Williams when she was giving birth to her baby and realized that it was after she had her baby, she had symptoms of, I think it was a pulmonary embolism, and she was begging for care, and eventually they ended up rushing her into surgery and saving her life. But in the beginning, people were not believing her for that. So it also shows too that even if you are a famous athlete, yes, obstetric violence can impact you. Being pushed into medically unnecessary birth interventions by healthcare providers. It's pretty atrocious, some of the things that I've heard providers say when they're trying to push somebody into those interventions. They may say, your baby will die. If you don't do it, then we're going to get a court order against you. So threats like that are made. Also, sometimes refusal of pain medicine when it's requested too. I've worked, there's a family friend who was refused an epidural because they said that there was no anesthesiologist on call during the 4th of July weekend. Which, if you know anything about the 4th of July, yes, you do have an anesthesiologist on call, because people injure themselves a lot with fireworks on the 4th of July. And also sometimes refusal of requested birth interventions. So like with Sumaya's example of the woman who requested having an episiotomy because she was subjected to circumcision or female genital cutting. And they decided not to provide one until the last second. That's putting that person through unnecessary pain. But obstetric violence and medical violence, it isn't just confined to birth care alone. So it's much more expansive than that, and also includes reproductive care, especially for sterilizations. There were a lot of Indigenous folks in the US and Canada who were forcibly sterilized by the Indian Health Service. For years, I think they said somewhere between 1960 and 1970, about 50% of Indigenous persons who were of reproducing and childbearing capabilities were sterilized by the Indian Health Service. Is what I found out the other day when I was taking this free online class. Also, withholding contraceptives unless a person agrees to invasive pelvic exams. Pelvic exams are not medically indicated in order to give you hormonal contraceptives, although for a long time that was considered part of what was medically required for you to be able to get that prescription, but there's not evidence that it's necessary. But there are benefits, of course, there are benefits to reproductive health exams, but it's not necessary to prescribe for prescription of hormonal birth control. Okay, also, if your provider has ever refused to take out your IUD or the Implanon and tried to talk you out of it, that's another form of it. In Iowa, actually, a couple of years ago, we had a law passed in 2017 that bans the use of pelvic exams without consent for educational purposes under anesthesia. So for a long time, in actually most US states, in teaching hospitals, they will have students perform pelvic exams on anesthetized patients without getting consent from that patient, often for surgeries that aren't even gynecologic health related too. So now there's paperwork that has to be completed. I know because I've done medical accompaniments to surgery at UIHC, and they have to ask the patients before they can sign the consent forms. And there's a special section where you have to sign off on it that says you consent or you don't consent to having pelvic exams performed on you under anesthesia for educational purposes. But again, just because we have that law in place doesn't mean that it doesn't happen, because it has happened since 2017. And I think it's punishable by, it's like a misdemeanor. Okay, so also that, a lot of things involved in that reproductive healthcare violence, leading patients to believe that non-evidence-based care is standard and required. So there's a lot of folks that I talk to who believe in things that are straight out of the 1950s, because that's how their providers have been practicing for so long. I've also talked with people too that still receive pap smears on a yearly basis, and they don't want to. It's not indicated, or at least it's not recommended by the major medical organizations in the United States that you receive a pap smear every year. They recommend that if you receive a normal pap smear, you get one every 3 years, and then after you're 30, I think it's every 5 years. But of course, you can still ask for one on a yearly basis, but it's not medically indicated. Also, like STI shaming patients for the number of sex partners that they have too, that's not acceptable. Force pregnancy testing to receive routine care. So maybe many of you have gone to the ER and you're complaining that your shoulder is broken, and they're requiring that you have a pregnancy test to treat you and investigate it. And they actually, like I went into the ER like a couple of years ago. They tested me without my knowledge or consent, and they also charged it. It's like $60. They charged me $60 for that pregnancy test. And I know darn well that that's $10 at Walgreens, but whatever, that's an aside. I won't go into that here. Okay, so also I want to outline too that intersex genital surgeries that are performed for cosmetic reasons are pretty routine here in the United States, but they're not medically necessary for the most part. There are some that are medically necessary and typically have to do with the infant's ability to urinate and not having an obstructed urethra. But so that's like a common practice in the US, and it's been common since about the 1950s. And it can include everything from cutting off the infant's clitoris because they deem it to be too big, to having numerous surgeries to normalize the genitals because they believe that the psychological effects will be too great on the infant, but that's not substantiated in the research. So if you understand obstetric violence, I want y'all to realize this isn't just a couple individuals who are bad apples, okay? This is a systemic issue. It's built into the way that the hospitals, clinics, etc. do care. Physicians, any medical practitioner is not immune to having biased attitudes. So when we think about violence as a whole, we think of it kind of in this format. To get to the top of the pyramid, genocide, you have to start out with the foundation. Biased attitudes, microaggressions, misogyny, homophobia, transphobia, ableism, racism. So they turn into acts of bias, including that dehumanization, throwing slurs at people, to discrimination, and so these are the building blocks that make it into the systemic discrimination that we see with lack of access to housing, political discrimination, funding certain school districts more than others that traditionally have maybe like more white students in them. Like I think about in Waterloo, how the school districts were funded and how oftentimes West High School had a lot more funding than East High School, and East High School also had a lot more Black students in it, and that's no coincidence. Additionally to like employment discrimination, so deciding I don't want to hire this person because of identities that they might hold. So all of these are the building blocks to bias motivated violence like murder, rape, assault, other forms of terrorism, and genocide. Bias is systemic, and our violence is built on the tolerance of it, right? So you have to have tolerance of the biased attitudes in order to get to the top of the pyramid in the first place. Obstetric violence kind of works in the same way. So we have tolerance towards the biased attitudes in medical spaces. We have tolerance towards some of the things that are lower on the pyramid but are still very harmful, like jokes about birthing plans leading to C-sections, language allowing or letting a pregnant person to do something, birth horror stories and jokes about pain, loss of dignity in birth, telling people all that matters is a healthy baby, but that's not true. The birthing person matters too. And so when we have tolerance of this type of language and dehumanization, it morphs into that bullying and intimidation in the healthcare setting, or threats of that baby's safety, or mocking somebody's pain or suffering. And then it morphs into the forced procedures. So that dehumanization is what builds up to I don't have to get consent. I am a doctor. I'm in charge of this person. Like in this moment, I'm taking care of their body without regard to what they want done with it. So this is where we're going to talk about how sometimes obstetric violence is sexual violence. So we know that obstetric violence is about power and control, and it's about lack of consent. We know that sexual violence often is about penetration and touching of genitals and anal orifices. And I mean, of course, like there's other ways in which it manifests too, like sexual harassment, sex trafficking, etc. But when we think of rape as a whole, that's typically what we think of, that penetration or touching of genitals and anal orifices in an unwelcome way. Obstetric violence and sexual violence don't have to have sexual motives. So because they're about power and control, we know that it isn't necessarily about somebody being unable to control themselves and, you know, ravenously lusting after the person that they're assaulting. It's about the fact that they want to take power and control over that person. And we see that similarity in obstetric violence as well. Sometimes obstetric violence is sexual violence because it involves the penetration and touching of genitals and anal orifices with the lack of consent, and it's done for the power of control. Power and control, excuse me. So that's how we know that sometimes obstetric violence is sexual violence, and it is something that we need to start considering in the sexual violence movement and in the work that we do here with our rape crisis centers. Obstetric violence is actually pretty pervasive in the United States. About 1 in 3 birthing people experience it, but we know that the numbers may be even a little bit higher than that. So out of 2,000 doulas that they, not just doulas, but childbirth educators, labor and delivery nurses in the US and Canada, they found that about 90% have witnessed a care provider engage in obstetric violence. I know I have witnessed a care provider engage in obstetric violence multiple times. I've even witnessed sexual assault nurse examiners engage in obstetric violence. And it's not okay, but it keeps happening and it's still permitted in medical settings. We also know that it has a lot of the same effects as sexual violence too. So about 9% of birthing people go on to develop PTSD, but it's not just about the PTSD from that experience. It's also postpartum depression and other perinatal mood disorders that are often correlated heavily with birth trauma. And what does birth trauma encompass? It encompasses obstetric violence. So we know that that can be a direct result of going through obstetric violence. There's also little accountability for providers as well. So y'all should actually check out this article. The Atlanta Journal-Constitution did this whole series where they were investigating the problem of sexual abuse by physicians in the United States. So they looked through about 2,400 cases in which, okay, so the US physician was found guilty of sexually abusing patients. And out of those 2,400 cases where they're found guilty, 50% of them still kept their medical license. What they do instead is they say, okay, we want you to have a chaperone in your practice with you. Who's employing the chaperone if you're in private practice? The physician that's been convicted. So then that chaperone's income is controlled by the person who sexually abused their patients. So is that person really receiving true accountability? Should they even be working with patients? Probably not. A lot of times too, like the only recourses for most obstetric violence incidents are reporting to the state medical boards and litigation against the provider. But if you're not a rich person, you don't have the money to engage in that litigation against the provider too. I think it's important to note that birth care isn't always evidence-based under the medical model either. So that's, again, like we're relating back to in earlier slides when we talked about the pressuring towards the procedures which are not indicated as medically necessary. It happens a lot, and it's actually built into hospital policy that these procedures should be done. So for a long time, people had done routine episiotomies, and we find that it actually does increase the incidence of tearing when it's done without a medical reason. Also, continuous electronic fetal monitoring during labor. It's recommended by the ACOG that they use intermittent fetal monitoring, but oftentimes that fetal monitoring is done because it's about protecting the provider from getting sued if there's a complaint later. And having that continuous fetal monitoring increases your chances for a C-section and unnecessary C-section. Additionally, too, birth while laying on your back. Some hospitals won't allow people to move around in labor, get up, walk. We are made to get up and walk around in labor because it helps with the descent of the baby. Birthing on your back, it can be comfortable for some people. Everyone should be allowed to do it if they want to, but if you're being forced to do it, that's not okay. And we also know that if you're birthing while laying on your back, it increases your chances of vaginal tearing too. Additionally, we see a lot of prohibitions of vaginal birth after cesareans or VBACs. While there is a slight increase in the chance of uterine rupture if you've had a prior cesarean and you do a vaginal birth later, it's like less than 1% from what we've read in the research. So prohibiting a person from going to do a VBAC isn't necessarily evidence-based. Also, we see a lot of routine inductions when somebody's less than a week past their due date. Research tells us that most people, not most people, most babies are born at about, I think it's like 40 weeks and 5 days or so. Or maybe it was 41 weeks and 5 days. Well, okay, I can look that up for y'all later and get that stat for you. It's not the most important thing. But we do know that a lot of people go past their due date, and how due dates are calculated tend to be based on the person's last period rather than trying to judge it based on what the ultrasound shows for how many weeks along that person is. So due dates are not an exact date. It's kind of just like a guesstimate time frame for when that person's going to have a baby. Also, like prohibitions of eating during labor. So a lot of hospitals will require that the person not eat during labor and only consume ice chips because they are scared that if a person needs a C-section and has to go under general anesthesia, that they'll aspirate their food into their lungs, basically. They'll come up their esophagus. We know that the chances of aspiration, even in those circumstances, are not, they're not completely impossible, but they're not actually as common as you'd think. And I've got like a lot of links that I can give out to the webinar attendees to look at these evidence pieces too. And also having frequent vaginal exams during labor, especially after somebody's water is broken, it increases your chances for having an infection later on. So when the birth care is not always evidence-based and it's built into the way that the hospital provides care for people, and they're pressuring people towards that care, obstetric violence is built into the way that we provide birth care in the US. Let's talk about our, let's just get a better understanding of our provider options in birth care in the US. So most people in the US go with an obstetrician or gynecologist or someone who's based within a hospital setting. I think they said like only anywhere from 1% to 4% of births in the United States are done at home. So most people birth in the hospital and they birth with an obstetrician or gynecologist. So they're specialized in complicated pregnancies. But part of that specialization in the complicated pregnancies sometimes involves viewing childbirth as a significant medical event and potentially unsafe. So they offer routine medical interventions for these births to keep them safe because that's what they believe will contribute to a better birth outcome. And the medical interventions are seen as preventative care. The medical interventions they use may also be a lot more invasive than you would see used in the midwifery care model. So midwives, it's a diverse profession. Some are certified nurse midwives, so they've gone through nursing school and have also got training to be a midwife. Some are certified professional midwives or otherwise direct entry midwives. So receiving training with just midwifery as a whole and then going into practice. That's actually how my great-grandmother did midwifery care. She was a lay midwife back in the 1940s and 50s, and she was just trained with other midwives to perform that service. Midwives specialize in normal pregnancies, and by normal we mean uncomplicated because normal is kind of a heavily loaded word for a lot of people. So they view childbirth, or at least the midwifery care model views childbirth as a natural process that's usually safe. They're more likely to wait and do watchful waiting than offer more invasive medical interventions early on for the birth process. And they also try to look at birth care from a holistic model focusing on overall well-being, whereas oftentimes obstetricians and gynecologists have restricted timeframes when they're working with patients because they have so many patients now. especially in Iowa, where we have a shortage of birth-related healthcare providers too. So in the US, the majority of births are attended by doctors rather than midwives, but that's not actually true in most other countries, especially in countries that even have better maternal health outcomes than us. Midwifery care is a lot more common in places like Europe. To understand why obstetricians and gynecologists are the way that they are, we need to kind of get a feel for birth and gynecology care in the United States. So let's go through the history a little bit here. So up until the mid-1800s, midwives attended nearly all births in the US. I will say that I took a course from Deidre Cooper Owens on racism and gynecology, and so that's where I sourced a lot of this information from. It's actually for free. You can find it. I would love to give you the link to that because it's right out there. It's on video on the web, and it's about an hour long. But we also know, okay, so African midwives were making up a bulk of the midwives that were helping provide these birth services in the US, not just to the Black community, but also to white women who were giving birth as well. As slavery grew, the African midwives started coming over, serving everybody because they had those skills from the countries that they were taken from, and sometimes maybe were taught by other people that they were with. Okay, so doctors, on the other hand, were derided for the lack of knowledge that they had or medical education. You didn't actually have to go to medical school to practice as a doctor in the United States. Typically, if somebody was going for gynecological surgery, that was seen as quite a risk. Most surgeries at that time were exploratory because we had so little knowledge, and we also didn't really have germ theory down that well. So typically, if you were going to a doctor, especially if it was for a surgery, you're pretty desperate to get your medical problem taken care of. Male doctors were discouraged from looking at female patients, so they would kind of just reach their hand up the person's skirt, turn their head to the side, and feel whatever it was that they were looking for, which isn't a particularly effective method for treating a lot of different gynecologic health issues too. These, let's talk about like the fathers of modern gynecology too in the US, because to understand how we morphed into the obstetrics, primarily obstetrics being used model, we have to understand how gynecology morphed over time. A lot of people might know about James Marion Sims because he was practicing his surgical techniques and learning them on enslaved women, specifically Anarcha, Betsy, and Lucy were three of those whose names we actually knew, but there were several people that he experimented on whose names we don't know. So he is credited as the inventor of the modern speculum as we see it. And he also was credited with the techniques that we use to repair the vesicovaginal fistula, which is a complication of childbirth. He perfected these techniques by performing them on unanesthetized slaves. So he's performing surgeries on enslaved women without anesthesia, and of course they're enslaved, so they don't exactly get to consent or not consent to these procedures being done. But he's not unique. Deidre Cooper Owens goes through that in the lecture that she talks about how there are several others that pioneer gynecological techniques that are doing what several others are doing because of the racism that was a characteristic at that time. Are they products of their time? No, nobody's excused of their racism regardless of what time they were born into. But they are still engaging in that dehumanization, which enabled us to have the medical knowledge that we have today. Okay, so additionally, Francois-Marie Prevost is considered the father of the C-section. He performed a lot of early C-sections on Haitian women without anesthesia. Many of them died. Ephraim McDowell performed experimental surgeries on enslaved Black women to remove ovarian cysts. He was successful in doing that, but he killed at least one person. And so like these folks there, you'll notice that they are performing their techniques on enslaved Black women in the United States. A lot of what we know about gynecology today came from the rape and torture of enslaved Black women. this is building the foundation of what gynecology is in the United States today. Additionally, Georges Cuvier, a surgeon, he also ran the National Museum of Paris. So there's this is indicative of the dehumanization of enslaved women too. There was a South African woman named Sarah Bartman who he kept a menagerie on display for most of her life. And when she died, he preserved her brain, her genitalia, and her spine. And these were part of an exhibition in the National Museum of Paris until 1974. And her body parts were not buried until 2002, and they were returned to South Africa. And it was my understanding that Nelson Mandela did some negotiation to get those parts of her body back. So of course, we've got these folks, they're doing these absolutely abhorrent procedures on enslaved women. And that provides some of the foundation for racism in the medicalization of childbirth too. So a while ago, back when the American Medical Association was forming, they saw midwives as competitors. Male physicians wanted to take over the field. They thought that they could do a better job of it. And they had people who were associated with the American Medical Association, the AMA, deciding to publish papers and become public influencers of taking over the profession away and taking it away from midwives too. So like J.W. Williams in 1912 publishes a paper titled The Medical Education and the Midwife Problem in the United States, where he's referring to midwifery care as barbaric, and he thinks that it needs to be phased out completely. And they suggested initially, when they wanted to phase it out, that they wanted to start with urban communities first and then move over to rural communities. I think what's important to note too is that the AMA sees the childbirth as a huge area where hospitals and doctors can profit in too. So a lot of what doctors were doing at the time was they were revolutionizing birth care with the use of different tools and instruments to justify the increased price tag. Joseph D. Lee also was a leading professor in obstetrics in the United States, so he had a lot of influence in that way. He took his personal battle against the midwives with his writings because he was advocating against their profession as a whole. So he also created a lot of processes that enshrined the medical intervention in birth, including prophylactic forceps deliveries. So that involved, and this is actually how the majority of, there's at least 12 people in my family that were born this way. So you put somebody to twilight sleep and then use forceps to help deliver the baby while the person is out. And then they wake up and they've got a baby and probably a very sore body too. But a lot of his writings from the early 1900s help enforce the idea that birth was a medical problem. It was pretty easy for them to work towards phasing out midwives in the United States because a decent portion of midwives were Black women providing childbirth services. So let's talk about grand midwives. So grand midwives are also known as granny midwives, were traditional Black midwives in the United States, and they attended up to 75% of births in the 1940s in the southeastern United States. And so they were typically practicing as lay midwives, relaying that knowledge and providing that training from person to person, having mentors in it. Beginning in the early 1800s, though, with the help of the AMA and the help of all of these major figures, they are phasing out midwifery through the use of creating laws that prohibit them from practicing or requiring certain types of licensure for professions that they've been doing for years and years. And it was easy to get the American public to believe that care in the hospital setting and care with obstetricians was safer, even after it had such a bad reputation early on, because we're racist, because people had a lot of feelings about Black women, and they maybe saw a lot of the methods that they used, especially with traditional care, because they involved a lot of holistic healing methods, and there was sometimes spirituality involved in it too, sometimes not. But they saw that as like the ways of the old and not necessarily like something that they wanted to partake in. They see obstetrics as something that's high tech and has all of these tools. Okay, so in about like the mid 1900s, nearly all of the lay midwives are systematically ousted by using the legal measures. And then it, of course, disproportionately impacts Black and Indigenous midwives, especially like Black midwives, because they were providing so much of the birth care in the United States. So then make it up to 1933 and you know, you've only got like 35% of births occurring in hospitals, but by 1955, the number rises to 95%. And that's kind of like about what we're stuck at today too. And it has an impact on birth outcomes. So hospital birth as a whole isn't like, having birth at a hospital isn't necessarily bad. I don't want to paint that picture. But some of the processes, especially the not medically based medical interventions that are a part of birth, have impacts on birth outcomes. It's not so much where, it's the way that we do birth care in the United States. So we actually have one of the highest maternal mortality rates in the developed world. We rank about 46th in the world. Additionally, too, we have a ridiculously high C-section rate. About a third of people end up getting a C-section with their birth in this country, which is not comparable to other countries with better maternal health outcomes. The WHO thinks that the number should be somewhere around 15%. Anything above that is considered excessive. And a lot of this roots back to the medically unnecessary interventions that we have. So unfortunately, the medical interventions that we have, they can be good in a lot of different births, but part of the side effects that they have is that they can cause what we refer to as the cascade of interventions. So because somebody has been induced and the contractions often are much stronger with an induction, it can cause fetal distress. And if the fetus is in distress, you're more likely to have a C-section. One thing tends to lead to the other, or you have like a routine episiotomy and you have a much deeper tear because it wasn't medically necessary to have it in your specific birth. So it does continue also to morph into a maternal health crisis. So thinking back to the earlier slides where we talked about the legacy of medical racism in the US, that was the building blocks for what the Black maternal health crisis is right now. We know Black birthing people are 3 to 4 times more likely to die from pregnancy-related complications than white birthing people. And that's not because there's something inherently different about the bodies of Black people. No, this is because of racism from providers. We know that there have been multiple studies indicating that Black people are given less pain medication than white people for the same illnesses. And a number of providers, I think in one study it was as high as 50%, believe myths like Black people have thicker skin. You are statistically more likely to die in surgery if you are Black. And that's not because your body is different. Again, it is because providers have these implicit biases that enable this type of thing to happen, to be done, rather. It's not just happening, it's like something that people are actively doing. Okay, we also know like Black babies are more likely to be admitted to the NICU. Also, Black women are routinely denied pain management medications and local anesthesia for gynecologic procedures because people believe that, a lot of providers believe that Black people don't experience as much pain as white people. And a lot of this information too, like if you want a resource that talks about it in depth, the Black Mamas Matter Alliance is really good for that. And they've also got a toolkit for steps that they think should be taken to help combat the Black maternal health crisis in the US. So I want to end the portion where I'm talking with a question. Are there ways that you see the legacy of medical racism impacting your role as a sexual assault advocate today? Does anyone want to speak to that? Y'all?
Feel free to raise your hand or use the chat box.
It's okay if nobody wants to speak to this one too. I know that I see it a lot in my role. Even just doing medical advocacies at the hospital, working with Black survivors, I see ways in which triage nursing staff at the ER treat them differently than I would see white survivors treated a lot. I think like it's important to note too that when gynecology in the United States is built on the rape and torture of enslaved Black women, how can we expect it to be good right now when we've done practically nothing to advance it past that point and haven't really done the work to eradicate racism in medical spaces? I guess I'll go to the end if nobody wants to raise their hand, but I've got time for questions.
Storm, there was a comment on the chat box.
There's a comment? Okay.
Yes.
Yeah.
Cool.
So it says generally just how different folks are treated differently by the same providers in similar scenarios.
Yeah, definitely. I observe that a lot too. Do y'all have questions? What's the Maya raised?
Yes, let me unmute you, Somaya. Okay, you can unmute yourself now.
Yeah, I don't know if this is relevant or not, but I've been with a woman. She's a woman of color, and she was going through an abortion because the stillbirth. The anesthesia was really very light. They didn't give her enough anesthesia, and I mentioned that a couple of times, and they told me, yeah, we gave her anesthesia, but she kept expressing her pain. She insists I would be with her in the room, and she was in pain from the very beginning until the end, but they didn't increase the anesthesia, and I didn't have any explanation for that, and I didn't comprehend that. I did talk to them. They talk to each other. One of the doctors talked to the other one and they say, okay, give her like, increase it by whatever the dose, or, but I didn't see that really. She was in pain. She was in a lot of pain. And I learned on that day they cut the fetus into a small pieces. I didn't know that when they performed the abortion. So it was quite painful, and I passed out because she was in pain and there was a lot of blood. So they put me in the bathroom and they gave me some drink. So it was a very heartbreaking experience for that woman and for me too.
Yeah, and I know like, cause, well, for the rest of y'all who are on the webinar, me and Sumaya, we work together. And she's told me this story before, and I think it's like such a classic example of obstetric violence in that they just like had such a blatant disregard for that woman's pain and her well-being too. And also too, just like it, like some of y'all may be thinking back on different things that you've observed, like a lot of us have observed obstetric violence, especially if we've done medical advocacy with survivors. And it does have a pretty bad effect on advocates. I know because I live with it too. I saw, Shalisa, you unmuted yourself?
Yeah, I was just gonna read another comment in the chat. And so it says, access to follow-up care differs.
Yeah, I see that a lot too as one of the ways, because they'll give different sets of instruction or different sets of like access to follow-up care to people depending on how they perceive that survivor, especially perceptions of race. Were there other questions from y'all?
Everyone's really quiet now. We Storm does have their email in the slide. If you have any follow-up questions or anything that you want to talk to them about. And Taylor says, can you share the info for the class you mentioned?
Yeah, it's like on all bodies, it's like .com. Like, I'm gonna like see if I can pull it up on here.
We could also include it in our follow-up email with the resources, Storm.
Yeah.
So that they get a comprehensive like list of all the things that you've talked about so far.
Yeah.
We are at 11:28, and if you all don't have any more questions, I want to thank Storm for presenting on this topic that is awesome. It's important to our work. The movement is very, very lucky to have you and Shalisa, and with all of that knowledge. So this was a great webinar as a foundation for the next webinar. So we do have part 2 coming up next Thursday at the same time. If you haven't registered for that already, please do so. I saw that a lot of people were registering last minute for this one, so hopefully we were able to accommodate everyone. Let's see, we do have something else here from Taylor. I have also been trying to gather some information about midwives, doulas that are available in our area. Are there resources you know of for getting connected with existing services in Iowa?
Taylor, where are you located in Iowa? Because that will depend on what resources are available to you. Yeah, Shalisa's got the same idea. Great minds think alike, don't they? I know that I'll talk a little bit about the Iowa City area, central southwest Iowa. I know less about central southwest Iowa. I know more, so I've worked in, oh, you are like way south. Okay. I know that I have worked in 2 different towns in this movement too. So I've worked in Des Moines and I've worked in Iowa City. It really depends on what your individual community is like. I think that I have a lot more luck finding other doulas here than I would in a smaller town, especially like other midwives too, because we are a slightly larger city. I wouldn't call us enormous by any means, but we do have some resources. So like I've connected with the doulas of Iowa City. They have kind of like a group that a lot of them buy membership to and are a part of. And they promote their practice like 4 times a year, or at least they did so in person before COVID happened too. But there's so many different types of doulas and midwives too. So if you're looking at midwives, some hospitals have midwives employed, especially folks who are like, so if you're a certified nurse midwife, you're more likely to work at a hospital. That doesn't mean that you always work at a hospital. But pretty much everybody who's involved with hospital-based midwifery is a certified nurse midwife, whereas you'll also see certified professional midwives or direct entry midwives are doing more home birth services across the United States. There's also like, so I'll talk a little bit about midwifery too. Midwifery and home birth, they aren't illegal in Iowa, but they're also not really regulated. About a couple of years ago, there was a group of midwives and doulas who went to the state legislature. They were asking for some sort of licensure and certification to practice in Iowa because it would open up the ability for them to provide prescription medications or get a hold of things like Pitocin. Pitocin is a medicine that's used to induce people, and also it helps mitigate postpartum hemorrhage, which can be life-saving if you have access to it. And a lot of the direct entry midwives or like certified professional midwives don't have access to that because we don't really create laws around or regulate midwifery, especially like home birth midwifery as much in Iowa. So it does like open up opportunities, but also to sometimes regulating midwifery and having a board for that can have some downsides, in that they will mandate that certain unnecessary parts of care become inaccessible to people. There's also a lot of midwives who are afraid to practice because they're afraid they'll be charged with practicing medicine without a license. But there was a case that went through in 2013 where the judge, this was here in Iowa, ruled that it's not a regulated profession. It's also like not classified necessarily as medicine. So they weren't willing to charge a midwife with practicing medicine without a license. But it's kind of like, it's such like a vague thing. I see a question from Sumaya in here too. How do you think we can find ways to do something to bring this issue to the light and make people aware of it? I think talking about it too. Everyone knows someone who gave birth because you know your mom or your birthing parent in some cases. But okay, so you know at least one person who gave birth, and you probably know a lot more than that. I think it's important to create a culture where people can talk openly about their birthing experiences, because there's so much shame and stigma behind having trauma. Oftentimes people will say that that they feel ashamed for being traumatized by the birth because they got a healthy baby in the end. And a healthy baby is a great outcome, but your health matters too. And we have to take that into account. And we need to start asking the question, is the birthing parent okay? What can we do to make them okay? How can we also like start looking at too, like how can we advocate for our birthing friends in medical spaces too, since most births in the US occur within a hospital setting. And also like educating people about their rights as well. I tried, so other things that I try to do, I try to actually have a lot of conversations with healthcare providers. I do a lot of like little continuing ed things, or go into some of the classes in the College of Nursing at the University of Iowa and talk to students about medical abuse and what that looks like, and try to really outline the importance of getting consent from your patients before you touch them and not coercing them into things. Because you have to instill into providers early on that obstetric and medical violence isn't okay. And they will get the opposite messaging from a lot of other instructors that they have when they start doing their clinical rotations. We have to change the culture before we can actually see birth outcomes improve. So we can legislate this all we want, and laws are useful, but that's not going to stop it from happening. It's just one piece of the puzzle that involves us changing that culture. I think Planned Parenthood, yeah, I do think Planned Parenthood facilities would benefit from a lot of this information. Something that like, yeah, and Shalisa was talking to providers, doctors, nurses, birth workers, advocates, practicing everyday consent, yes. Because consent, as like we talked about earlier, isn't as systemically enforced within the hospital. And a lot of times, like if you file a complaint against a provider who provided non-consensual care, also known as assault, it gets swept under the rug. The hospital doesn't do anything about it. They don't reprimand that person, fire them, do anything to take them out of their position of power. There's no accountability. And yeah, and it's true that the laws protect a very specific groups of folks. So like, if you know that the law exists and you have access to go and file a police report, or access to a lawyer to sue somebody and have access to the income to do that, then you can get accountability for what has happened to you. But if you don't have access to those resources, accountability is a lot less likely to happen for you.
And Storm, there was a question on the Q&A that I think Shalisa is asking for clarification. The question was, are you familiar with baby-friendly hospitals and how it might relate to these topics? And then Shalisa asked, I am unsure what you are referring to. What do you mean by baby-friendly? So if Danielle, you want to raise your hand so I can, yep, okay, here we go.
Hi, you guys, can you hear me?
Yes.
Yes.
So, so baby-friendly hospitals, because my background's actually in women's health, and from my understanding, baby-friendly hospitals are almost like, from what I understand, like certified hospitals that only promote breastfeeding. And so I was just curious if, if you had any information relating to this topic, if somebody doesn't want to breastfeed and they're in a baby-friendly hospital, and kind of how it relates to this topic. I mean, are they forced? Are they coerced to do that? I mean, I was just thinking about some of those other situations that kind of relate to, autonomy and your own choices over your body.
Yeah, and I think actually we're just like ending up World Breastfeeding Week too, so this is a really timely question. Okay, so I will say this, especially when we're working with survivors, when I've worked with them, I don't see a lot of people wanting to do breastfeeding, and a lot of that is related directly to trauma. So if your breasts are or were part of that body that was violated in the sexual trauma that you've endured, breastfeeding can be a really touchy issue for the populations that we're working with in rape crisis work. Going into a baby-friendly hospital, as it's termed, so a hospital that only endorses breastfeeding, that can be a bit of a hurdle in a way. I think that one of the problems that we see, so there's like a lot of shaming around what a parent's choices will be, right? We see like, oh, you need to eat all organic, you need to breastfeed. Some people say you need to have a hospital birth. No, you need to have a home birth. No, you need to have an unmedicated. No, an epidural is your best choice. So there's so much conflict, and I think a lot of birthing persons feel turmoil over these choices and feel a lot of judgment from people in their families, their friends, colleagues even. And I think like it's interesting that we term it like a baby-friendly hospital, because to be baby-friendly would mean that we're providing support to the parents so that they can provide the care that they see fit to their kid. And that might involve bottle feeding the child. It might not be accessible. Breastfeeding isn't accessible to a lot of people. It's a great option though. Like it definitely has a lot of nutritional benefit when compared to formula, but it's not accessible for everyone. And so like sometimes there have been people like just like in my life that I've worked with who have been shamed by the providers that they're working with because they're choosing not to breastfeed. I think that even I wonder if my mom had went through it too, because I know like my mother had thought about breastfeeding with me, but then because she had a C-section, she had issues getting milk flow to come in, and she hadn't basically held me or seen me in like 3 days or so. So like it took a toll in that sense, and she's like, you know what, I'm just gonna do bottle feeding. And like sometimes when I say what my mother said, my mom said, I wanted to do bottle feeding because I wanted my body back. Being pregnant was a very miserable experience for me. Like people look at me when I repeat what my mom said and they're shocked by that. They're taken aback. Like, why is this shocking to you? This is her experience. And I turned out okay, I think. Kind of, well, it's debatable.
NAFLA did provide some additional information. NAFLA says baby-friendly hospitals don't generally force breastfeeding. They are just opposed to pushing formula, often given in birthing gift packs. And the baby-friendly classification is a form of accreditation that hospitals can choose to pursue.
Okay.
I believe that it's like through UNICEF. Someone correct me if I'm wrong.
That's right, it is, because I was just reading Jack Newman's Guide to Breastfeeding.
Mm-hmm.
Yeah. Yeah, it is. It's one form of accreditation through UNICEF. Like I think on the other end too, there's formula companies do a lot of lobbying, and also like they're giving free samples to the hospital, and they're like through that lobbying, through making connections with providers, they're putting a lot of influence on what happens in care. You see it with drug providers who make connections with healthcare providers, and you know, sometimes people are incentivized and all of a sudden that healthcare provider is prescribing more of a certain drug. The same thing can kind of be said about formula. So formula companies make connections with providers and hospitals, and then suddenly you get free formula as a part of your baby gift pack, even if it was something that you did not particularly want. And that's very intentional. And it does, like, it contributes in a way to, so like breastfeeding is so complicated, right? People need way more support with breastfeeding if it's a journey that they want to go on, because it's not something that is easily relayed. It looks self-explanatory. You think baby boob, they'll know what to do. They got a sucking reflex. Simple. Not true. While they do have a lot of those natural instincts towards breastfeeding, including like that breastfeeding crawl that they do right after birth, where they will crawl up a person's abdomen and attempt to root around and try and find the breast. And if you see videos of that, like, it's wild. Go look it up on YouTube. I love it. But babies sometimes have a lot of issues getting a good latch, and getting a good latch is often like the root of breastfeeding problems. So then providers will push formula, give formula in birthing gift packs too. When formula becomes like the option that's recommended when you start having breastfeeding problems, rather than seeing a lactation consultant and being given the support that you need, like, it's no wonder that a decent number of kids are formula fed in this day and age. But yeah, like, it's pushing a lot of hospitals will push like certain products too, and that's not good, because it's just another thing of capitalism. Why am I going to go in capitalism here? Because I'm in a webinar. Okay. Were there any other questions? No?
I think for time, we should get ready to wrap up, and then it sounds like Jocelyn will be sending out some resources to folks who are registered for this webinar, and they can reach out with more questions directly to you or myself.
Okay. Cool. All right. Well, dang, look at y'all. I'm so glad that y'all came. Thank you for coming to this webinar. I was very excited to be a part of it. And if you have any other like follow-up questions too, please email me. I don't have Shalisa's email listed on this slide, but if I don't know the answer to a question too, like, I might ask Shalisa, because she has a lot of great knowledge in this area. But yeah, I guess we can stop the broadcast.
Yes, and again, thank you so much to both of you. The webinar for next week, it will be on the impact of advocacy related to this topic. So I'm really, really excited about that. Like I said, if you haven't done so, please register for that. If you stuck with us through the end, you will get your 1.5 credit hours towards your recertification. Also, if there are questions that came up during this presentation that you feel like you want to be addressed for the next webinar, feel free to send them to Storm, Shalisa, or myself, so that they can also cover that in the next webinar. So I think that's everything for this webinar. Thank you all so much again. I hope you have a good day, and we'll see you next week, hopefully.
Thank you.
Bye, everyone.